Welcome, everyone. It is wonderful to have you with us today for the 2025 Faces of Lung Cancer briefing. Our title is Stories That Unite Us, Change That Moves Us. My name is Dr. Rosalyn Juergens. By trade, I'm a medical oncologist. I work out of the Juravinski Cancer Center, and I'm a professor of oncology at McMaster University. But the title that I am proudest to wear today is the current president of Lung Cancer Canada. Lung Cancer Canada is the only Canadian charity focused exclusively on lung cancer, and we take that responsibility very seriously. Everything we do is about moving people to earlier diagnosis, faster access to effective treatments, and better support across their journey. Before we begin, Lung Cancer Canada acknowledges that our work takes place on the traditional lands of many nations, including the Mi'kmaq, the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. These lands are now home to diverse First Nations, Inuit, and Métis communities. This acknowledgement is also a commitment to ensure that lung health resources, diagnostics, and treatments are accessible to all Canadians, especially Indigenous communities that continue to face systemic disparities in access and outcomes. So today's event centers on Lung Cancer Canada's flagship publication, the Faces of Lung Cancer Report. Each year, it brings forward powerful stories, essential insights, and evidence-based recommendations. It's an indispensable resource for anyone involved in care, advocacy, and research. This year's theme marks a shift from awareness and access to impact and transformation. Across Canada, care is changing, but not fast enough. Too many people are still waiting. Too many treatments have been delayed. The stories you're going to hear today are hard, but hopeful. They reveal gaps, spark solutions, and, I hope, sustain momentum. Think of today as a preview. The full report includes these stories in greater depth. There's extended interviews, context, as well as practical resources, and we invite you to read and share them. Taken together, these stories point to what must change and who must move. Turning these things into action is our job. From my perspective, our priorities are clear. First, we must find and treat lung cancer earlier by strengthening primary care pathways, screening, imaging, pathology, and biomarker testing. We are going to make a massive impact on lung cancer outcomes. We need to shorten time to patient getting to that right treating physician. We need evidence to become consistently and fairly balanced across the provinces. We also look to support the entire journey, including social work services, care networks, as well as tools that can help meet people where they are. We're trying to put lived experience at the center so that the patient and caregiver perspectives will guide research, policy, and program design. We're building coalitions. Durable change will only happen when clinicians, patients, policymakers, industry, and communities pull together really for one voice. I want to thank our community. I feel such privilege to be part of the greater lung cancer community, and there is very few other spaces where the collaborative efforts that I see are truly so wholehearted. From coast to coast, our clinicians and researchers bring frontline expertise to our programs as well as our advocacy. Equally essential are our patient and caregiver advocates. Their experiences ground our work and keep the urgency front of mind where it belongs. I would now like to thank today's sponsors. Today's event is made possible with the generous support of our sponsors. Our sponsors of today's event include Amgen, AstraZeneca, Bristol Myers Squibb, EMD Serono, Janssen, Merck, Pfizer, Regeneron, Roche, and Titan One. Thank you for partnering with us to strengthen the lung cancer community and improve care across Canada. So I think we have an incredibly rich program ahead. You're going to hear paired perspectives that tag team the pathway from finding and treating lung cancer earlier to living with lung cancer and new phases of survivorship, to the power and support of turning hope into action. And that's what we're here today to do, is turn hope into action. So as you listen to today, I invite you to consider two questions. What is one thing that we can scale nationally? And what is one action you or your organization can take forward in the next 90 days? Lots for you to think about. So with that, we're going to get started. So I'm going to begin by introducing our first session. This first session is titled Finding and Treating Lung Cancer Earlier. And we're going to connect real diagnostic journeys to clinical readiness and faster access to treatment. So it's my pleasure to introduce the three panelists who are going to be participating in this section. So first, I would like to introduce Judy Hollingsworth. She was born and raised in Winnipeg and then moved to Vancouver, where she has built her life. She's been married and has raised a son. After being diagnosed with a blood clotting disorder, something called antiphospholipid lupus anticoagulant, that made her pregnancy and childbirth difficult, she retired early and poured her energy into volunteering, supporting school-aged children in her local hospice. She's a former smoker who lost both of her parents to lung cancer, and Judy has never hesitated when she has seen a poster seeking volunteers for lung cancer screening, and she signed up to help advance research that could spare other families what hers has endured. The next panel member is a friend and colleague. His name is Dr. Brendan Sheffield. He's an anatomic and molecular pathologist, and he's actually the founder of the Advanced Diagnostics Division at William Osler Health System in Brampton, Ontario, and he serves as their divisional lead. One of the most important roles, from my perspective, that Brandon holds is he's director of the Molecular External Quality Assurance for something called CPQA, which is Canada's National Pathology Quality Program. He's the regional lead for Mississauga, Halton West, and Cancer Care Ontario for that region. He's a prolific author. He's authored a recent textbook on molecular pathology. He has many peer-reviewed papers. And his work really focuses on high-quality biomarker testing to make sure that we can provide the precision cancer care in the real world. Brandon's been a long-time member of our medical advisory committee and always is an incredible speaker. And then last but not least, we have Dr. Lorraine Bell. She's a pediatric nephrologist at Montreal's Children's Hospital. She's an associate professor of pediatrics at McGill University. She founded and directs McGill's pediatric kidney transplant program and leads pediatric transition to adult care. Well, in May of 2020, Dr. Bell was diagnosed with stage 4 lung cancer. It's an experience that now informs her advocacy and offers a rare dual perspective on how access, navigation, and timely precision therapies can and must improve for patients. So Judy, we'd like to start with you. Can you talk to us about your journey and the importance of early detection and screening?
Good morning, and thanks for having me. My journey began originally when I came across a poster in a physician's office. It was looking for volunteers for a lung cancer study. So although I was a bit hesitant and nervous, I kind of knew that I had to apply because I had been a smoker and both parents died of lung cancer. With my father, when he had surgery, they opened him up and just said, you know, it's too late, and closed him back up again. Because in those days, you know, there was no early detection or anything like that. And then with my mom, it was sort of through a chance visit to the emergency room for something else, and they discovered hers, and it was the same. You know, it was too late to do anything. So they just said, you know, no treatment, no medicine, no nothing, just go home and live your life. So she lasted about 10 months after that. So for me, I was a kid that had pneumonia quite early in life, quite serious. At the age of 2, I was hospitalized. Again, when I was 7 years old, hospitalized, and then continued to get it a couple times in my life. So I knew that my lungs probably weren't that great. And being with the smoker, I thought, I had to apply for this. So it led me to a research study, which was conducted by Dr. Stephen Lamb here in Vancouver, the early detection program. So I applied and signed up, and there was a number of forms and appointments and things like that. So we started out, and I started going for my, sorry, I'm just looking at my notes here. It was a two-year study, to my knowledge, originally. That's how long it was going to last. But that was back in 2010, I think. So I'm still in it now. And this is, 15 years later or something. So I went and had, questionnaires, visits, interviews, blood tests, breathing tests, bronchoscopies, CT scans over the course of the 2 years. And this led to a detection of cancer. So, I mean, in one sense, that was very great that they found it, and it was early. So it was just left as is. They identified what it was, and I continued with follow-up. And then in 2014, I had a wedge resection surgery with Dr. John Yee. I've remained in the study, and I'm still in it today, like I said. They find new nodules. They tell you what they find. They tell you what they're going to do. So my CT scan gets changed. Sometimes I go every 3 months, every 6, every 9. This past appointment a couple of weeks ago, I got a clearance for 12 months. So that's good again, And he's just an amazing doctor. And I was very lucky, I think, to get in that program, So that's been 15 years. And another thing, I've been diagnosed with rheumatoid arthritis. I'm taking a chemo drug for that. They say sometimes that might be of help too, keeping certain things at bay. So, I'm not sure what it is, but I guess I don't know, maybe I'm a lifer. I don't know how long they're going to keep me. So I've really enjoyed it. He's a fantastic doctor, both him and Dr. Yee, who was my surgeon. So I can't thank them enough, Otherwise it would have never been found, right? Had I not go for that. So we really need to do something about it. I mean, at the time I signed up, there was nothing that I knew of as far as support groups, or nobody ever said anything. I know when I went for my surgery, I think they gave me a booklet and said, go home and read it. And that's kind of all that was, said to you. So it's really important to get the awareness out there. Early detection, that's my thing. That saved my life, right? So that's sort of my story. I mean, and it covers, there's such a stigma with the smoking thing and everything. And I mean, nowadays, probably more than half the people that get lung cancer are non-smokers anyway. So, there needs to be more awareness. I'm happy that I found the group. Originally I didn't know anywhere to go, anybody to talk to. So in my neighborhood, I knew a few ladies that had a breast cancer support group going. So I joined that for a little while until I found the others. So now I do the online with Michelle, and these groups are fantastic. Technology's made this easy. So that's kind of my story.
Oh, Judy,
Hopefully
I'm
we
so
can do
glad that
better.
you picked up that flyer that day.
No kidding. No kidding.
Sometimes things happen for a reason, and you are striking the message home that we're hoping that gets heard, is that the only thing that you have to get lung cancer is a pair of lungs, which we are all born with. And there are so many pieces of what takes someone down the path to get a diagnosis of lung cancer that we don't understand. And so thank you for taking that step of being part of the movement to try to expand screening. So thank you so much for those words of inspiration.
You're welcome.
So I'm going to pass this now to Dr. Sheffield. So from your clinical perspective, how does Judy's experiences reflect the changes and opportunities in early detection and diagnosis? So Brandon, why don't you tell us a little bit about your thoughts on this space?
You know what? I agree. I just want to say it was so great that you picked up that flyer that day as well. And while screening may have started with these visionary programs like Dr. Lamb's, this is now available across Canada, and we've got publicly funded screening opportunities. I know that Ontario is now reimbursing this, and it's really great to see this happening, because the story that you told about your parents is very reflective of what the typical experience of lung cancer would be like before we started to make such advances. And definitely there are much better treatments for advanced stage lung cancer right now. We're not sending anybody home with no treatment or anything like that. We've got great options available. But the opportunity to detect a lung cancer earlier is really the best way for us to intervene and make the biggest difference. So that really we're seeing lung cancer diagnosed at an earlier stage, more stage 1, stage 2 disease, and the treatment that we get from a surgeon, they can be the most effective treatments. And so participating in that screening program is absolutely, it's such a positive and fantastic thing. And the one thing I will add, and I know Dr. Yee is an amazing surgeon, and Dr. Lamb's just an amazing lung cancer doctor, but there's a third doctor in there. There's a pathologist who makes everything possible. And when you go for those biopsies, there's somebody there looking at those under the microscope who helps sort out who needs to go see a surgeon versus who needs to go back to the screening program. And I guess that's why I'm here today, is to really highlight the role of some of the doctors who are helping taking care of you who you don't see. The work that we do in the laboratory really helps, I think, contribute to making these screening programs both really effective and also really safe.
Well, thank you so much, Brandon. I really appreciate your personal perspective, and I know we need to continue to do better with regards to how the technology functions, et cetera. And I'm really looking forward to some of the adjunctive work that I hope will parallel along with CT screening to help us really identify the people who are truly at risk. And I know you're going to be part of the forefront of figuring out how we can deal with smaller and smaller samples to try to figure out how to answer these questions. So I'm gonna pass the script over to Dr. Bell. So you have a very unique perspective, both as a healthcare professional and a patient. What stands out most from your perspective for the barriers that patients are facing when they're trying to access new treatments? Oh, we've got to get you to unmute yourself, Dr. Bell. Oh, I still can't hear you for some reason. My apologies, everyone. We're just having a technical difficulty here. Tried muting. Have you tried turning up the volume on your have you unmuted your computer itself? So sometimes it's all the advancements in technology, yet here we still are with struggles with technology. I know this morning. Oh, let's see if that helps. You've got earbuds in. Oh,
Can you?
yes, I can hear you now. Hey, there we go. Those little AirPods were our problem.
Yeah, they were working before when I tested them.
That is how it always works, right? The test thing doesn't always come to bear. So I will ground you back. So, what do you find are some of the barriers that you can see that people are facing when trying to access treatments?
I think there were a lot of barriers. I guess there's the time it takes for results to come back, which seems very long when you're waiting. But I realize when I've been on the other side, it's probably not that long. I think the other thing is the knowledge, and then the other thing is drug approval. I was kind of shocked when I was diagnosed with lung cancer. I was used to taking care of patients, not having to be a patient myself. But I had back pain for about a month, which got progressively worse. And then in the last week of May 2020, I had started to have trouble walking. So I saw a neurologist who ordered an urgent MRI the same afternoon. And it turned out that I had a tumor that had invaded one of my thoracic vertebrae, and which accounted for all the pain. It caused it to fracture. But it had actually gone through the vertebrae and it was putting pressure on my spinal cord, and that's why I was having trouble to walk. So after that, I had to spend the evening in the emergency room of one of our major teaching hospitals. And it was arranged for me to have surgery, decompressive surgery, the next day for my spinal cord with a wonderful orthopedic surgeon. But I had to wait in the emergency room overnight. And I think, and this was during COVID, so it was a trauma center, the emergency room that I was in. So it was pretty crazy. I have a sense of humor, and I was able to kind of look at all the strange things going on around me, like I was watching a television show, and it was pretty strange. But then finally, the next morning I had my surgery, and then when I woke up, I could not move my right leg. And when I asked the orthopedic surgeon, will I be able to move it again? Will I be able to walk? He didn't promise me anything. So I couldn't walk at all for at least a week. Then I could walk a little bit with a walker. The thing that was hard, and I'm not sure how this could have been made better. The thing that was hard is that the hospital that I was in has 3 separate sites. It has one for orthopedic and respirology and for urology, and it has another site where cancer treatment is centered. And they're about 15 minutes away by car because of traffic lights. So I was kind of stuck up in this other hospital, this orthopedic hospital, but not at the oncology center. So I was getting some updates from respirologists who happened to be on service and who were rounding on me, but wasn't getting too much information. I didn't get to meet my oncologist. I was told that, and these are the delays that kind of scared me. So they were, and this is probably in Dr. Sheffield's field, but the initial tissue for my analysis was from my vertebra. And because it has to be decalcified, I guess there's sometimes problems with getting adequate DNA or RNA. So it was suggested after I had all my CT scans after I presented, and it was discovered that I had a lesion in my lung, which is actually adjacent to my esophagus. I had no cough, no pulmonary symptoms. It was decided that I should have a biopsy done by a pretty neat technique with an endoscopic ultrasound, where they went down my esophagus because the lesion was next to my esophagus. And then they took, I assume it was a fine needle aspiration biopsy through the ultrasound down my esophagus, and that was sent. But unfortunately, it didn't get analyzed until, because of hospital budget reasons, didn't get analyzed until it was determined that my first sample was inadequate. And then that one got analyzed. So it took, to me, it seemed forever, but I think it was really just about a month before the final results came in. And the first sample didn't show the mutation I have. I have a c-MET exon 14 skipping mutation, which I guess is rather unusual. I'm not sure. So it didn't show up on the first biopsy. It showed up on the second. But that whole time didn't know what was happening. Being in pediatrics, I don't know too much about lung cancer. It's not something I saw in pediatrics, and plus I was in kidney disease. So at that point, I was stuck in a hospital away from the oncology center, not really knowing anything about lung cancer. And so I was reading what I could on my computer, trying to understand things. And I got pretty scared because I think by the time information trickles down to sort of summary websites, it's kind of old. So what I was seeing was that I probably had a life expectancy of less than a year. And I'd gone from being, a month before I was on call, I was doing nut call, I was looking after kidney transplantations, I was, completely normal, and all of a sudden this happened. So it was quite a shock. But anyway, I finally saw my oncologist after about 6 weeks. And by that time I was in a rehab hospital because I still couldn't walk. The rehab hospital was quite awful. So I was in rehab actually for 5 weeks after my orthopedic surgery. But I saw my oncologist in the middle of July, so that was about 6 weeks. And then they prescribed for me, the results hadn't all come in, I guess. So she initially prescribed for me because I had a high percentage of PD-L1 in my first biopsy. I got pembrolizumab. But then the results came in for the second biopsy, and I was switched to crizotinib, which was all that was available in 2020. And so I started on crizotinib. I had a bit of a rough time. I got quite sick about 2 or 3 weeks after. I think maybe because the two drugs were in close proximity to each other, I developed a high fever. Like I've never had high fevers before, so it was quite a shock too. And that lasted for 3 weeks. So it was pretty, it was a long period. So I really wasn't very well for about 8 months, I guess, after my diagnosis. And by the winter of 2021, I was able to start walking again, initially without a walker and then with a cane and then on my own. So the story seemed to have a pretty happy ending. I was kind of shocked. The crizotinib side effects were not too bad. Initially there was some nausea, but after that it was okay. And I felt fine. I went back to work actually 1 year after I went off. So in June 2021, I went back to work, but just seeing outpatients, not doing night call. And I felt fine. I was really positive, got a puppy the next year. And then in 2023, I was feeling really well and was even planning a trip to the Caribbean in December. And then October, I was having PET scans every 3 months. So initially, just to say, when I presented, I had metastases everywhere, all through my abdomen, my chest, my bones, scattered everywhere. And even while I was in this rehab hospital, I had a little subcutaneous one, like a little quarter-sized nodule that I could see actually in the mirror under my skin in the upper abdomen. So what was amazing, this is going back a little bit, was when I started the crizotinib, that little coin-sized lesion, it was like this big, it just melted away. I could feel it disappear. And I'd been feeling it for almost a month. So I knew it was there. I knew it wasn't my imagination. It just disappeared within a week. It was gone, that little. So that was a really nice feeling. So I was having PET scans regularly. Then my PET scan in October 2023 showed that I had an adrenal metastasis, and there was for 2 centimeters, and I had also, it looked like I probably had something in my cerebellum. So then I got an MRI. Turned out I felt fine. Like this was just screening. So I had 8 metastases in my brain at that time in October 2023. 2 of them were fairly big, were relatively big, like close to 2 centimeters, and the others were tiny. So my oncologist switched me at that point to tepotinib, which was not approved when I first started treatment. And I found that drug a little bit hard to take. I still find it hard to take. I'm on it still, but it makes me tired and makes me short of breath. It causes all kinds of side effects that I found hard to adapt to at first because I still couldn't think of myself as a patient. I still wanted to be doing everything. So anyway, we started the tepotinib, and then I also saw a radiation oncologist, a neuroradiation oncologist for my brain. And she was a bit worried about the size of a couple of the lesions, so she sent me to a neurosurgeon. It's another hospital to go to the neurosurgeon. And she followed me closely, and they were planning on doing, I'm just trying to think back. So she was thinking of doing stereotactic radiosurgery. For anyone who doesn't know, it's just like, it's quite amazing. It focuses all the beams at one place. So I was pretty impressed with all the technology. I was looking at this like a medical person. And So it turned out before I was to get that, they did another MRI in radiation oncology, and 6 of the 8 lesions had disappeared in the space of a month. So we waited a little bit longer. This took me over the Christmas from 2023 to 2024. Then in 2024 January, I went back and there were still the 2 bigger lesions that hadn't gone away. So then the neurosurgeon followed me, and I got radiosurgery for those 2 bigger ones. But I still had some cerebral edema, so I was on steroids quite a bit. And I got put on, because the lesions didn't completely clear up with tepotinib, I got put on pembrolizumab. And I have to say that in the interim, my oncologist had asked for approval I live in Quebec, from the Quebec government to pay for tepotinib, and they refused because I had already had crizotinib. Even though crizotinib does not penetrate the brain, they had made these rules with the scientific board in Quebec called INES, that they would not pay for tepotinib in someone who had failed a tyrosine kinase inhibitor, so in the same family. So they refused to pay. My oncologist appealed it. They refused a second time. So at that point, I was switched to pembrolizumab. But when I was in pembrolizumab, I was having cerebral edema off and on related to the surgery, or related to the radiation. So I was on steroids off and on. Anyway, the pembrolizumab didn't seem to do anything. I got more metastases in my brain when I was on a whole bunch more. I had more radiosurgery. I guess they were caught early this time, so they were easier to treat. So they were treated. But then I started to get some other symptoms. And in June of 2024, I had to go to the emergency room. And it turned out I had quite significant cerebral edema by that point. And they looked like there were more metastases to treat. So I was seeing my radiation oncologist again. But in the meantime, my lung oncologist put me back on tepotinib. She and my husband convinced me, because I hadn't enjoyed the side effects too much. Anyway, I got put back on tepotinib, and what had been seen in that June emergency room visit, 6 days after I had restarted the tepotinib, was all gone. When I went to see my radiation oncologist for a planning CT and MRI, and it had all resolved. So I was back on the tepotinib. We reapplied to Quebec, and they wouldn't pay again. And then with all the reasons that I had responded, quite quickly to the treatment, and then the system is she filed an appeal explaining to them that crizotinib did get into the brain. They still refused. It's kind of like, I think as I understand it, INES, this body that makes the rules for what drugs are approved, they probably just say, you have to fulfill certain criteria. And then I think a bureaucrat just looks at the boxes and just checks off no. So it was refused. And this time, on the second refusal, because she appealed it, I had the option to, within 60 days, to make an appeal to in Quebec, it's called the tribunal. I guess it's a court or tribunal. I'm not really sure how it translates, but it's called the tribunal, administrative tribunal. So I had to do that. And then it could take up to 6 months to 12 months before they hear the case. So I went through the literature and prepared stuff as best I could. And that's, I guess, where I had an advantage as being a medical person. I was able to read the medical journals. I prepared my case, but I was starting to feel worse and worse. And during that fall period, so in November, I appealed it, but in October, I had to have brain surgery because my cerebral edema had got worse. So I had to have one of my tumors removed from the left cerebral area, which was very near to the speech center. So it was quite frightening. But as you can see, my surgeon was good. I can still talk. And he's pretty happy when he hears me talk. So I had that surgery done, but I just didn't feel very well up until, through Christmas. It was kind of miserable. Then it turned out I had increasing cerebral edema, and I had to go to the hospital as an emergency on New Year's Day, January 1st, 2025. And the edema was quite serious this time, so I ended up having fairly urgent surgery to remove the cerebellar lesion. So this time it was a posterior fossa tumor, so that I think is worse. So I had more surgery, and I still didn't have any approval from the government. I was still paying. This drug costs almost $10,000 a month. So I had to pay out of pocket for it. I guess I'm fortunate as a physician, I'm self-employed, like I'm sure you guys are too. So I had to have a retirement, pretty good RRSP, because that was beyond all my retirement income. So I had to withdraw money from my RRSP to pay for the drugs. Serrano agreed to pay $2,000 of the $10,000 a month, so it became $8,000 a month. And then I felt like, I don't know if it was all the brain radiation and surgery I had, but I was getting tired. I felt like my concentration wasn't very good. And a neighbor said I really should have a lawyer. I thought I could defend myself adequately because I thought I could read the medical literature. But anyway, I'm glad I took his advice. I found a wonderful law firm that specializes in medical cases. They really helped me. I sent them all of my documents. They really sorted things out. And finally, it was heard in May of 2025, and the government agreed to pay, finally. So it cost money to go to a lawyer. I was sort of afraid of how much a lawyer was going to cost, but it cost less than a 1 month supply of my drug. So it was really worth it. So now it's paid for.
Oh, that's really
Here I am.
inspiring,
So
Lorraine.
yeah. So I think there's a couple of lessons learned. One is that you have to advocate for yourself. You have to have someone else advocating for you. And I think it's really good to have someone with you when you go to your medical appointments. My husband I didn't want to restart the tepotinib because it made me feel sick, but he and my oncologist convinced me to retry it in the summer of 2024. And I guess that one thing. The other thing that I think that could be helped is I was able to look on the computer and look things up on the web about lung cancer, but I had no information at my fingertips that I could read, except what I could read on medical sites like Up to Date about, and then try to read a little bit. When I found out what my mutation was, I could look up that. I have to say, I was so thankful for the pathologist. In fact, one of my classmates is a lung pathologist. And so I called him when I was terrified. And then somebody that I used to work with who is a lung pathologist in molecular pathology, happened to be a kidney biopsy pathologist too. So I used to see him regularly, but he was the one who specialized in the molecular pathology. So I felt like I had people I could ask questions to, but I think reasonably they didn't really want to talk too much about it, but at least I knew what went on behind the scenes. I had a really good relationship with our regular renal pathologist, and she was central, I want to say, to all of our diagnoses. Like in kidney disease, pathology is the central point. So yeah, but I think the other thing is when somebody tells you no, you have to kind of look at your options and be ready to fight a battle. But I think I needed more help than I realized. And I would have liked to have had some information on lung cancer in that 2 months that I was in hospital. It was COVID, so I couldn't go out. Plus like I said, I couldn't really walk. I couldn't go home until I was able to navigate the stairs in our house. So 2 months at a hospital was a long time not to get to ask anyone any questions. I would have loved to have had something to read from the lung cancer community. I did have great support at our hospital. There was, a nutritionist because I lost my appetite, and there was a psychologist that was, I guess, part of the fundraising that they had. But I think the advocacy and being prepared to, I hate to say it, to fight the system. And realize when some decisions just don't make sense.
And I think, Dr. Bell, that's what binds us all together, is we are here on individual levels trying to figure out how do we move the field forward, and how, even though it may seem small, that each of our voices has the opportunity to be amplified through the group effort. So I want to thank you so much for sharing your story and perspective. I'm going to ask one question to this panel, then we're going to move on to the next panel that we have. So, again, I think each of your voices really speaks to how we must act. I think that's what I'm taking from all of your stories. We need to reduce delays, we need to expand access, and we need to ensure patients aren't left behind. So if you could give me each, one practical change to move patients from diagnosis to the right treatment faster, what might it be? So I'll start with Judy and see what she thinks about what that one change might be. Oh, can you unmute yourself, Judy?
Sorry.
There we go.
Yeah, I mean, we've got to get the word out somehow, somewhere. I mean, even if you get, like you say, a diagnosis, then where do you go? You know, nobody knows. Nowadays, I mean, the medical system, it's horrible out west. I don't know what it's like out east, but you can't even get an appointment at a doctor hardly. But when you do, there's got to be somewhere that, whether they're posters on walls or on social media, or can a GP, you know, let you know that there's a screening system out there. I mean, the screening is done here now. I talked to Dr. Lamb the other day. He said they think they've done about 18,000 already. But I don't think it's back east yet, is it? The new screening program?
It's bits and bobs across the country. So we're
Okay.
still working on trying to get it accessible across the board.
Yeah, but I mean, all the places I've ever been, or hospitals or offices, nobody has, and those are for appointments about your lungs. There's no information anywhere, no pamphlets, nothing. So I don't
So we
know.
need to get the word out is what Judy's got for
Yeah.
us. Dr. Sheffield, if you've got one thing that we could do in this next year to try to improve the system, what would it be?
Absolutely. So, I just have to say, Dr. Bell, that was an incredible story, and it's great to see you here and looking amazing and doing so well. It's just fantastic to see what such a great outcome 5 years now after your diagnosis. There was a couple of things that stood out to me about your story. In particular, the access to tepotinib. About 5% of lung cancers have this MET exon 14 skipping mutation. And drugs like tepotinib, capmatinib, these are very, very important for the treatment of this disease. And the access to these drugs in Canada is terrible. I think the access is actually best in Quebec compared to the rest of Canada, where we're all behind where Quebec is. So that's one thing we're really relying on Lung Cancer Canada to help sort of lead that effort and help garner better access for our patients with this specific type of lung cancer. The part to me that stood out about your story as the lab guy was just at the very beginning when you're just sitting there in the hospital waiting for your results, and you said you had to wait 1 month. And to me, I just think that's too long. You're very lucky that you were able to walk again after that. And that could have cost you your ability to regain your walking and recover from that surgery. So, we know that anybody in that situation across Canada, they might wait anywhere from around 1 week to up to 2 months to get that result. And, it's never going to be entirely equal, but I think 2 weeks is a really reasonable benchmark for us to set. And we should be aiming that any patient coming in that scenario shouldn't have to wait more than 2 weeks. And I think the best way for us to achieve that is to make sure that every lung cancer patient has a molecular pathologist looking out for them. It's somebody who can act behind the scenes. Your pathology, I think, is a lot like checking your bags on an airline flight. We know if the leg room's bad or the food's not good or they played a really nice movie, but we really have no idea what's happening behind the scenes there. And what's going on with your biopsy and the tissue is a lot like that. So you want to make sure that there's somebody looking after you in the parts of the hospital and the parts of the care that you can't see and visually criticize on your own. So I think having a molecular pathologist look after the parts of your care that aren't right in front of you, I think that'll really help make sure that those most important samples, those ones that are coming from patients' spines that are threatening their quality of life, are getting the best testing, and that it's coming in a timely fashion. So
We
that's
need
my
benchmarks, is what Dr. Sheffield is saying. We need someone who's actually paying attention to what these timelines look like, so that we can be kept accountable. Because right now, there isn't such thing that exists in lung cancer.
I think for me, maybe the initial biopsy report came with all the addenda of the molecular pathology, probably at the end of 2 weeks. But they wouldn't, even though a second biopsy had been taken, I think for budget reasons, the second one didn't get sent. And that's, hospital budgets are tight. I can appreciate that, having worked in a hospital. I appreciate delays. I can sort of appreciate some of the behind the scenes delays, but I think it was 2 weeks for each biopsy. So the result came through at the beginning of July. from May 31st. My surgery is on a Saturday, so that just delays things.
It just compounds things.
Yeah.
Do you have one last quick thought around what something we could do in this next year?
I think I'm going to go back to what I was doing in work before I stopped working. I was very interested in transition to adult care and getting my young, especially my transplant patients, ready to fend for themselves in the adult world. And we had all sorts of things that we wanted to prepare them for so they could fend for themselves in a more crowded medical world. And I have to say, I didn't really do all of those things myself. So it would be things like know all your medications. I think I knew that. Have somebody with you, write down all your questions in advance, write down answers. And those are some of the things that I didn't do. But I think having somebody with you and keeping a written record of what's going on and not being afraid to ask questions either during the visit or after the visit is important. And I think
Dr. Bell, we're going to tap you for our next version of our lung cancer guide. And we're going to put a section in there about lived experience from patients and advice from patients on how you can help yourself help the system.
Yeah. Okay.
Well, I'd just like to thank each and every one of you from this panel. Incredibly insightful. So thank you so much for each of you telling us your stories. I'm going to move on to the next panelist, and this section is titled Living with and Beyond Lung Cancer. These stories really remind us that life after lung cancer diagnosis can be multifaceted and that chronic care, quality of care, and long-term support deserve equal focus. So we've got a single panelist in this section. I would like to introduce you to Aurica. Aurica is a proud mother and grandmother who lives right here in Hamilton, Ontario, which is where I am located. She identifies as culturally deaf and communicates in American Sign Language. Born hearing, she lost her hearing at age 13 after a traumatic incident in her home country before immigrating to Canada. She's a resilient two-time cancer survivor. She first overcame breast cancer 13 years ago, and then she was diagnosed with stage 3 lung cancer in 2022 and had to face chemotherapy, radiation, and immunotherapy. She's a former assembly operator at Honeywell and is now retired and enjoys staying active in many aspects of her life. So I'd like to invite Aurica to talk to us about additional and unique challenges that you faced in the situation of living with lung cancer. So thank you, Aurica, for joining us today.
Hello, everybody. Hi, everybody. Thank you so much for welcoming me and inviting me to this. Oh, sorry, excuse me here, just a little bit emotional. I'm very happy. I'm listening to everybody's experiences and stories, and I've had a very difficult life and challenging and fighting. I was born hearing, as mentioned, and then became deaf, and so moving to a new country and experiencing a lot of the experiences in my home country, and then learning, that I had cancer, and then I was quite surprised. It was quite impactful for me to know that I had cancer a second time around. I didn't feel anything. There weren't any symptoms the first time around, and then getting diagnosed with breast cancer, going through that, and then getting diagnosed with lung cancer. Just to clarify, my cancer was stage 3A, T1N2, ROS1, NSCLC, and excuse the interpreter for mispronouncing adenochronicine. I'm not too sure if I pronounced it that right. So that was my diagnosis and my experiences going through that. Moving here to Hamilton, I moved here about 8 years ago. And that year in 2022, I was diagnosed with lung cancer. I didn't feel any pain. I didn't feel anything. I was healthy. I had some issues with my heart. I had a weak heart, so I had ended up in the emergency room, and in the emergency, they found through the diagnosis, they found a black tumor. And at that point, I had a feeling that it was cancer, but you know, I knew I had to continue fighting. I knew I had to continue through. The only issue is I was quite frustrated with the system because the system is not familiar with deaf patients. They don't know how to work with deaf patients in comparison to Toronto. When I was in Toronto, my experiences there was quite different. A lot of times there was no access. I had an appointment, but the interpreters weren't booked. I was so expected to bring a friend or bring a family member to interpret. Also, 2022, people were still wearing masks in the hospital, and so I wasn't able to see their lips, wasn't able to see if they're talking. I felt like it was a very robotic, machine-like medical model. I wasn't able to see their lips move because of the masks. There was no access. I had to continue advocating to let them know I'm deaf, continue advocating to let them know I need an interpreter, to advocate to let them know the agencies that they can easily connect through CHS, Canadian Hearing Services, to book interpreters and make sure that it is accessible. And so with my experience, I didn't want my family, I didn't want my friends, I didn't want to bring somebody in on my medical appointments for privacy reasons. I don't want people to be involved. On top of that, they are not professional sign language interpreters, so they would not be able to give me the full message, the full story, the full insights. They would be able to just sign words here and there. And so I highly recommend that, you know, any medical staff, anybody who is booking an appointment for any interpreter, any deaf individual, deaf patient, that they have to know how to book an interpreter. They have to confirm interpreter and to be able to make it accessible. A lot of times I had to miss my appointments or I had to get my appointments postponed because there was no access. And I thank God that I'm still living here and I had gone through that system and was able to get through it. But it's important to be able to also communicate with your patients via other technological means, not just phoning, but also emailing or texting, ensuring that some of those really strict policies pertaining to emails or texting have to be changed to make sure that they are accessible. And then again, as mentioned, sometimes there's a lot of information that's missed. As a deaf patient or a hard of hearing patient, they'd miss that information or they would call and they would miss that call sometimes with to be able to connect with me through a system, video relay system. They have to make sure that I'm in front of the computer and I'm watching out for that. So again, it's quite challenging. I have to sit here in front of my laptop to wait for a phone call and to make sure that, you know, the medical professional will call me. And sometimes I'm sitting here for an hour and a half, can't even run to the bathroom because I have to wait for the phone call. Or if I need to grab a drink of water, I can't do that. I have to do that quite quickly. Um, a lot of times too with the technology, it can be quite challenging connecting with me through the phone. Um, and so, you know, I think that there has to be a lot more resources. I wanted to ask a lot more questions. I didn't feel like I had a lot of information and a lot of access. And then when I had to get a follow-up and I had to get CAT scans and one of the CAT scans had a dye involved in it as well, I had to wait for hours. And then on top of that, I had to get my appointment rescheduled, wait for a time to make sure everybody is available, make sure that the interpreter is available. So all of that really delays. So, you know, I apologize for this, but I thank you all for your patience and bearing with me for all the emotions that I'm going through. And I do understand that as medical professionals, you have a lot of other patients, but patients who are deaf need a little bit more extra time for that communication piece and need that time to make sure that the interpretation gets through, make sure that maybe you document your notes and pass it along to the deaf patient so that that way they have that information, that report, and those answers typed up. I know that I'm not the only person living with cancer, and I know there are so many individuals who go through the system and have similar experiences. Um, and so, sorry, one moment for the interpreter. Sometimes, again, to get a hold of the doctor or get an appointment, there are a lot of waiting times, and so lots of barriers, especially as a deaf patient. So I do highly recommend, that you give deaf patients or hard of hearing patients, sometimes they need a little bit more time in their appointments, especially with the interpreters, and that communication piece. In addition to that, if you are reaching out to your deaf and hard of hearing patients, to make sure that you give, again, that follow up to make sure you're able to get a hold of them. You could use visual means, whether it be using a board or a computer, making sure that that appointment is visually accessible for deaf patients. If there is an emergency or if there is an appointment with a doctor, it would be a really good idea to make sure that they have a list of, maybe a waiting list of people's names, so that the deaf person knows when their turn is next and that they don't miss it, and know when they are next on the list, as opposed to sitting there. Because there are a few times where I missed my appointment. I was um, with an individual, and I asked them to let me know when they hear my name, because I was sitting there was no interpreter. And then that individual, that patient, went before me, and so I didn't have a means to have access to my appointment. I had to wait. Luckily, that time the interpreter arrived later, and so I was able to get in with the interpreter. Sometimes too, in the hospitals, they use a video relay interpreter, so interpreters on the screens, and sometimes it's really difficult. That's not very accessible. I do prefer interpreters in person as opposed to on the screen, because with my eyesight, sometimes it becomes a barrier. I do let them know in the hospitals that I want the interpreter to be in person. And so, now, especially with the technology and the machines and everything, um, there is a hospital here in Hamilton that wants to save costs and have a very strict budget, so they don't book interpreters in person. They only use interpreters on the iPad or on the laptop. And so sometimes it's not very accessible. I have to use my own technology, or the interpreter is struggling to hear the space because through the technology. And then sometimes I have to hold the iPad, but then I can't sign. And it's quite a struggle. It's not very accessible. Sometimes the iPad is falling, the wires are getting disconnected, and I'm missing the content and information. And honestly, it is so frustrating. I leave frustrated from my appointments. I wish that they're able to hear how frustrated and see how frustrated I can get, but communication can tend to be quite limited at those appointments. In addition to that, I think it's important, as I mentioned, to make sure that you have visual means to know which patient is up next, so that I have that access and know that when my turn is and what that waiting list looks like. Yes, so just that's a little bit of my thoughts, and thank you for listening to me.
Oh, thank you so much, Aurica, for your story. Communication is so critical in what we do, and just navigating lung cancer on its own is hard enough, and then you add these additional barriers. And I can absolutely appreciate how you have been met with challenge after challenge. I'm hopeful that as our country moves towards better access to electronic medical records that allows patients to be able to see into what's going on with their care, that will be one small step to be able to help facilitate your ability to feel engaged in your lung cancer. But electronic medical records don't help in the actual appointment themselves. You spoke very candidly about the emotional toll after your diagnosis. Day to day, what has helped you most to live well with lung cancer? Are there habits or supports or other mindsets you'd like to tell our audience about?
Thank you. Thank you for that. Um, Luckily and thankful to God that I have a mental health counselor. So therapy has helped me a lot. In addition to that, here in Hamilton, I found, sorry, one moment for the interpreter. Oh, Michelle runs the support group, the lung cancer support group that I am so happy I join in. I learn about people's experiences. I'm able to get to share my experience, learn about how I can maintain a healthier, stronger body. I know that I'm not alone. So that has been very, very helpful. CHS has helped me as well. And so I just keep learning. I'm very happy. I'm very proud of my children and my grandchildren. Seeing them grow up, that gives me inspiration and motivation throughout my days. I try to keep busy chatting with my friends, whether it be sometimes on video chats or once in a while. Um, we'll go out, and sometimes I reach out to my friends from back home, from other countries. I try to exercise. I also have a garden in the back, and that is very nice to look at. And traveling with my family. My family is very supportive. Sometimes they'll visit me on the weekend. They'll stay over on the weekend from Toronto. They'll do that a couple of times a month, and that keeps my spirits high. And keeping my schedule busy, making sure I'm organized. If I do have an appointment, if it's a CAT scan, one time I did have an appointment and there was no interpreter when I showed up. The staff had forgotten to reach out to get an interpreter, and that really does become quite frustrating. And so when that happens, I reach out to the interpreting agency to make sure that things are in check. And sometimes I'll call and make sure they have an interpreter before I even show up, just to make sure. So I try to be proactive in that regards, whether it be with my medication, making sure I have all my medication, making sure I'm up to date with my medication from my doctor. Sometimes I'll ask staff to explain what the treatment looks like to make sure I have that full understanding. And I'm very strong. I'm a very strong, independent person. I've had cancer, and I've survived. And thank God it's been a couple of years, and yeah, can't complain. Thank God.
Well, it sounds like you have just an incredible, multifaceted way of moving yourself forward. And we're going to look to you as inspiration on how, again, you can advocate for yourself. It takes a village. I really, truly believe that. And only if we bind ourselves together and we as a group try to help support both patients, their loved ones, and the whole system will we actually continue to move things forward. So thank you, Aurica, for sharing your story. I really do appreciate it. I'm going to move on to the next. Oh,
Thank you for including me. Thank you very much.
No, thank you for sharing your story. I'm going to move on to the third panel here, and this panel is really going to be focusing on support and system change. The importance of support for caregivers, peers, and communities, and really how do we connect these things directly to system change and equity of care? So we've got two panelists as part of this section. The first panelist is Bonnie Leung. She's a nurse practitioner in oncology, as well as a nurse clinician scientist at BC Cancer Vancouver. She's a PhD candidate at the University of British Columbia in the School of Nursing. And her work focuses on equity-centered lung cancer care, including geriatric assessment, navigation, and practical supports to help patients start and stay on treatment. She also helps convene the Emerging Lung Nurses Network to elevate nursing leadership in care and advocacy. And then our second panelist is Scott Lanaway. Scott is a Toronto-based marketing strategist, advocate, and member of our board at Lung Cancer Canada. He's inspired by his mother's experience with small cell lung cancer. He brings a caregiver lens to our national conversations on awareness, patient support, and policy, and uses storytelling and strategy to advance a more human and hopeful dialogue about this disease. So Scott, we're going to start with you. Can you talk to us about your journey as a caregiver?
Wonderful. Thank you so much for the introduction, Roz. And I'm so humbled and honored to be here and be able to participate. Hearing what everybody has to say is really moving and really brings home why it's so important that we're connecting on these issues to try to think about how we can do things differently in Canada to step up for people with lung cancer and caregivers, and to figure out a way to make things better, provide more support, offer better outcomes. So I'm going to talk to you a little bit about my mom, because I can't really talk about, abstractly about being a caregiver without kind of letting you know a little bit about the person who is at the center of this lung cancer experience in our family. I'll talk to you a little bit about my personal caregiver experience, and I make no presumptions around how my caregiver experience aligns with others. I think every human experience is so unique and challenging. There's different sets of inputs. But I'm going to try and give you a clear view on what that felt like for me, for my family. And then I'll share a few thoughts at the end about how I think that connects into the bigger picture of kind of, why it's important that we're here having this conversation and looking at information that's presented in the Faces of Lung Cancer report that's so critical to understand and having these really important conversations. So my mom's name was Diane. She was a awesome person, Diane Mackay. Last name was Mackay. She was born in Edinburgh, Scotland in 1950. She, in her youth, was an actress. She had me at a very young age and kept acting in local theater. She had a beautiful singing voice. She was incredibly artistic. She was a calligrapher and she did watercolors. She was curious. She loved to read. She especially loved biographies, reading biographies of old Hollywood stars in particular. She loved old movies as well. I used to watch a lot of old movies with her. She was an amazing cook. She could do probably any accent you could suggest. She could do it extremely well. She had an amazing sense of humor and a huge laugh. So when you'd get into something that was funny, it was like uproarious, and it was one of those kind of contagious things that you would get carried away with. So my mom's diagnosis occurred when she was 56. So, pretty young. And I'm 52 now. So as I'm kind of coming towards the age at which she was diagnosed, it's been giving me pause. And I've been, thinking about that, especially when you've got kids and where you're at in your life. My reaction to her diagnosis was shock, as I'm sure it is for most people. I was at work one day at the office, and she called and said, I have some bad news, and I've been to the doctor, and they've diagnosed me with small cell lung cancer. I didn't know about lung cancer. I didn't know the difference between small cell and non-small cell, and didn't really know much about anything. And but was very scared to hear this. And your brain first goes to, well, they must have made a mistake. I'm sure we're going to do more tests and get this figured out. Like maybe that's what they're worried about, but maybe when we go deeper into it, it'll be something else and something that we can deal with. But very, very concerned. So we were, we were all in shock, and then tried to do our best to, be there for her as things progressed and as things unfolded. And I mean, I think there are so many people on this call who have been through hard conversations. I've heard about some patient journeys here today that have just absolutely blown my mind. I mean, this is not easy. And, some of the healthcare professionals who we have on the call, and doctors, and, people who are witnessing these things and being present and being a guiding voice. It's very, very intense. And there's no playbook that you can just jump into that works for everybody. So we're all doing our best, and we're all imperfect, and we're all scared, and we're all trying to figure it out. So, my mom ended up going through in total. I mean, she was told she had 3 months to live maximum. And then she was sort of given information from her doctor about different chemo treatments she could do. So this is back in 2006. So bit of a different environment then. We didn't know anything about any of it. So we were just kind of, my mom, we didn't really have, you know, internet. I mean, I did for work, but at my mom's house, like they didn't really use it. And I was doing tons of research because as caregiver, I'm like, this is how I can help. I can research and learn and reach out to people and see if I can uncover something that might help. And like so many people do. Um, but at the end of the day, you know, the patient, in this case, my mom, kind of shows like what they need in the experience. And what she needed was, it didn't really help her to have a bunch of people coming up and saying that they'd done a deep dive on Google and found a study about this or that, and they're doing this somewhere. I mean, she wanted, she's like, I have a doctor, I'm scared. My doctor is going to tell me what I'm supposed to do, and I'm going to take it one day at a time. So, you know, the investigative journalism being done or research being done in her case was not helpful. And I completely understand why. I mean, if I put myself in her shoes, would I want to have a bunch of people coming at me saying, what about this? What about this? What about this? Ask about this. That said, it was already brought up in this call that in the system that we're operating in, it became abundantly clear to me that, like, as a patient, you have to advocate for yourself. You have to ask hard questions. I think you know, you're put in a bad position if you're kind of made to feel like your job is just to take information and show up when you're supposed to show up. You have a right as a patient to want to understand the why underneath what's being recommended and educate yourself and get supported and get good information. So, you know, I think there was quite a bit of an absence of that in my mom's case. The care felt very sort of kind of like reactive and disjointed, different people weighing in different ways, and it didn't feel very kind of centralized. There wasn't lots of great communication. So we were kind of left with like, okay, well, they told us we're switching chemo treatments and it starts next week. So I guess that's what we're doing. And I would secretly do some research and try to figure it out, go to the appointments with her. So she ended up going through 45 chemo treatments. She extended her life from what they said was going to be 3 months to about a year and a half. And she was willing to go through all those chemo treatments, which were very hard for her because she wanted to be here and she didn't want to leave. And at the end, when it had spread to her brain, she did cranial radiation. So she really was like kind of went 12 rounds as far as she could take it. And she was so tough in that way. So you know, we had complex family dynamics as well. This is something my sister and I had to deal with. It's like, and I think this is something that's not talked about too much, but there are, you know, difficulties in people's logistical situations and who they're with and who they're dependent on that you have to navigate as well to be a caregiver. And we had to figure all those things out as well. So it's messy, messy business, and it's scary because you love the person and you want to do anything you can to make it better. So the progression of the illness, I'll just give you like a few of my caregiver snapshots. So in the midst of all the craziness and not knowing how it's all going to go, managing to do a short walk on a sunny day, just going out walking down the street and enjoying the fresh air. The day that she came down into the kitchen and said, my hair is really falling out now. I think it's time to shave it. And I'm like, do you want us to do it now? And she said, yeah. And we got the razor and we did that together. And she, you know, like she didn't cry. She was being very pragmatic about it, but it was a big moment. It's like, this is really happening. Her wanting to go to a store and being able to get her in the car and go for a little ride and then thinking we can do the store if we get a wheelchair, and I'm organizing a wheelchair and bringing her around the store. When she was starting to need to take longer naps because of the chemo, so I'd go to visit, she'd often be in bed, watching her become more frail as time went on. To my sister and I, it felt like, you know, she kind of like aged 15 years or something. Like it was really hard on her. Being at her chemo appointments with her, sometimes joking around with her, distracting her, talking about what's in the news. I have a specific memory that is in the piece that's in the Faces of Lung Cancer report that always sticks with me. But it was a little bit early on, and she was still mobile. She was in the kitchen making herself a cup of tea and looking at the paper, and her head was shaved. And I was sitting there, and I was trying to work remotely while I was there with her, just so I could be with her. And I remember looking at her in the kitchen and just kind of seeing her silhouette and the sunlight coming in and having that weird moment of like, she's here right now. I'm with her right now. And this is impossible to believe, but like at some point, not that she's not going to be, and trying to kind of live with that, which, you know, this is the cost of this on families and patients and their families and loved ones is so massive. Everybody has their, you know, their version of that story. And New Year's Eve 1997, she really wanted to stay up for midnight. It was a big deal. We had her in the kitchen and she was sitting up, you know, to have some drinks, and she's like very frail, but had a really nice time. And it was like we were talking and really kind of like making the most of the moment, which became, I think, kind of like everything. That's kind of one of the things I learned. It's like everything else you're kind of worried about, it all falls away in that moment when you feel like you can just be present with someone. And at the end of that night, when it was over, she realized she actually couldn't use her legs anymore, and she had to be carried to bed. So that was another kind of big moment when we're like, okay, things are changing again. And then it went to, we had to get a hospital bed, you know, that was put in her living room, and figuring out how to make her feel comfortable and kind of go from one to the next, and just how can I be present and be supportive. So being a witness to all of that and trying to figure out how to support her. And as a caregiver, having no idea how to support myself. It's like you just throw yourself into what can I do right now in this moment that I think might be helpful? And you don't even have time to process like how it's impacting you. Um, she was really scared. So, you know, she had moments where she was like very, very scared. And that was awful because it was like hard to know how to support her. She was also really tough. I said she went through 45 chemo treatments and cranial radiation. That's tough. Like, I don't even know if I could do that. She was tough, tough, tough. She had a shirt, a little t-shirt that had a cartoon cookie on it. It said tough cookie. And my sister had one too. And they would both wear it when we were hanging out. And she really, really was a tough cookie. And I was inspired by her strength. For me, I think like for a lot of caregivers in that situation, you don't know how to support yourself. You are just trying to cope. It's a lot. Um, Something else that's come up here that others have mentioned, but not having access to good information. So things have changed a lot since then in terms of information that's available online. But at the time, we did not have access to good information. We were basically flying blind in terms of treatment options. Everything felt very reactive, and it was uncoordinated, cumulatively uncoordinated experience across the healthcare system as a whole. It was just stumbling into gaps and then trying to figure out how to troubleshoot filling that gap and getting partial information and just, you know, pushing. Nobody to talk to. So for my mom, you know, she didn't have anyone to talk to, and she was kind of private about it. It's a very private experience. Um, and she did find someone else who had a different kind of cancer who she could talk to. But then at one point she said to me, you know, like, it's not like cancer is cancer. Like everybody's unique and every cancer experience is unique. So it's not like just because you have cancer, it's like it's the same for all of us. So she really struggled. And I think she could have benefited if she had been able to connect with and speak with other people who had lung cancer. We didn't have anyone to talk to. I mean, my friend group, it was like if I said, hey, I'm stressed out or I'm not going to come out tonight because, you know, my mom has terminal cancer. It was like nobody wants to hear that because they don't know how to talk to you. They don't know what to say. So you're kind of just on an island. Um, Fun moments. We had uproariously fun moments throughout all of this. You know, the ebbs and flows, the ups and downs. You end up kind of laughing to the point where you're crying at different points, and these amazing moments. And just being with her as much as I could all the way through. My whole feeling was I want to see this through, and I want to be there right through to the end and provide as much support and comfort as I possibly can. And then in the aftermath, um, even though you know it's coming, this processing of loss, this deep grief, deep frustration, shock, probably some degree of PTSD, and for me, actually quite a bit of anger, because I just couldn't process like what had happened and the whole experience of her care and like how it went and how we got information and like it just it felt infuriatingly hopeless. And so that's kind of, well, that led me into sort of grief counseling, which connected me with other people. And I kind of realized, oh, well, when you talk to other people who've gone through something similar, it eases the burden. Um, and then eventually getting into contact with Lung Cancer Canada and realizing, oh my God, like these people exist and they understand this world of lung cancer and why it's important and what matters. And they understand that how important it is that we provide information and connection for people, for patients and caregivers. So wanting to be involved in that made me feel a little bit better. Like maybe I'm doing something that can help shift things a little bit. And so that was kind of what drew me to the organization. So I'll conclude with just a few thoughts on the big picture side of all this, some final thoughts. So towards the end of my mom's life, she's in a hospital bed in her living room. She was not conscious most of the time. Eventually, the community care nurse told us one day that she had passed the threshold of consciousness and would no longer be able to communicate with us, like she wasn't going to wake up, and that we should be prepared, that we were going to lose her imminently. So we sat with her in shifts around her bed, holding her hand, talking to her. I'm a firm believer in just because a person can't respond to you doesn't mean they can't hear you. And we would move her body to try to keep her comfortable and prevent bed sores. I'm being specific because this is like what it was. Like everybody who's been through it knows. And a couple of days later, one night, my door opened when I was fast asleep. My sister told me to come downstairs right away. And I thought, this is it. And I went downstairs and there she was. Her eyes were open and she was smiling at us. And it felt like a bit of a dream. And we had a brief, I'd say 1 minute conversation. And it was so amazing to hear her voice. And she actually chuckled and joked with us a little bit. But then we had to give her more morphine and she went back into unconsciousness and we weren't able to speak with her again. And she died early in the morning, a couple of days later on January 27th, 2008. So what I wanted to say is from my caregiver perspective and why this kind of matters to me and why I'm involved with Lung Cancer Canada. We know that every year, over 30,000 people are diagnosed with lung cancer in Canada. So my mom's name was Diane. So in my world, that's 30,000 Dianes. So that's 30,000 families. That's 30,000 groups of loved ones. So I did a rough calculation and I said, I think we could safely estimate at least 250,000 Canadians who are direct or indirect caregivers at any given moment and involved in a lung cancer experience. Then you add in all the healthcare professionals who are on the front line, supporting patients, having these conversations, going through these moments that matter so much. And you think about the emotional toll, and then you think about the logistical and financial burden on families, but also on the system as a whole, like really thinking about that. So we need to get some sunlight on this and do better for patients and caregivers, which is why we're all here and why I'm so happy to be here. And I think the information presented in this report demands action. There's an inverse relationship between funding and the impact of this disease. It's a grotesquely inverse. Relative to the impact, it should be the most funded and it's the least. So we can't turn a blind eye to this. It's not acceptable. But the good news, momentum is formed when people connect. Lung Cancer Canada exists solely and entirely to act as a connector and fulcrum to advance care, support, advocacy, and research for lung cancer in Canada. Lung cancer. There is no other focus going on here. And we're the only organization who is singularly focused on lung cancer. And I think that's really, really important. That's our why. And the reason why is because the needle can be moved and the needle is moving. We've heard some amazing stories of new treatments that are coming in, of people diagnosed at stage 4, incredible therapies. I've met some of the most amazing people through this organization. I wish I had known about Lung Cancer Canada, been involved when my mom was sick and kind of found a way to plug into this stuff, but we can do this better together. I think the more we connect about this together, the more we can do. So we need more connection, we need more voices, and ultimately more accountability. And to any caregivers on the call today who might be listening, I would say you're not alone. There's strength in numbers. Reach out to Lung Cancer Canada. It feels good to make a difference with people who understand you. And to go back to what Roz said earlier, let's turn hope into action together.
Oh, thank you so much, Scott, for that. I really appreciate your heartfelt thoughts. So our last speaker is Bonnie Leung. From your perspective as a nurse, what does meaningful support look like?
Well, first of all, I want to thank you, Dr. Juergens, and thank you to all the panelists who took their time to share their personal experience and showing, how important it is that we all work together. I'm very grateful to be a part of the Lung Cancer Canada family. And as a nurse, and some of the research that I've done with some of my colleagues, we know, and I think it's been highlighted with all the panelists talking today, that one of the biggest care gap is the time interval from the suspicion of having a cancer diagnosis to the person's first appointment with their oncologist. That agonizing wait to get the test done, getting from appointment to appointment, and sometimes get piecemeal information from one doctor to another and not really knowing what to expect next. It's a very distressing time, and often people don't know what to do, who to talk to, and where to get accurate information. I think that was really highlighted so far this morning or this afternoon. And in BC Cancer in Vancouver, where I work, we're very fortunate to have a nurse navigator who fills in some of that gap. So Kelly Zebrick, she's been in her role for over 12 years with us, and she's one of the first people that patients and family members talk to when they get referred to BC Cancer. And Kelly provides them with updates and guidance on symptom management and referrals to supportive care services like counseling and dietitians. And she really coordinates care with primary care providers and specialists. And to Dr. Sheffield's point, making sure that the biopsy specimens are sent to the molecular pathologist in a timely manner so that we can get those tests done and get those answers that we need to start people on treatment as soon as possible. And I think another care gap that some of the work that we've done is that there are certain populations that are particularly more vulnerable, like people living in remote and rural areas, those experiencing structural vulnerability, like those who are housing insecure or living in poverty, older adults and racialized minorities. People who identify as belonging to these groups experience added barriers accessing healthcare. Often it's unrelated to the medical condition. And as with all of us as healthcare professionals, we know the importance of social determinants of health. But I think as nurses, we are particularly trained to recognize the social and the practical and the emotional reality shaping the person that we're seeing in front of us. And cancer does not happen in a vacuum. It takes a village, as everybody has kind of highlighted, and it shouldn't end with just thinking about cancer treatments that we're offering, but everything else that comes with the person. And so I would argue that similar to kind of Kelly's role in the beginning of a person's cancer journey, there should be similar services that could provide additional support to people who are at risk of being left behind. And some of my colleagues are doing work on that with pilot projects, trying to support people experiencing structural vulnerability and accessing cancer care, getting older adults to participate in clinical trials, and accessing cancer and supportive care services is all very important work that we're doing. And the last thing I really wanted to highlight is better support for people living with and beyond cancer and their caregivers. So many amazing innovations have happened with our treatments now, and people are living longer and they're living well longer. And I have to admit, when I first started my role over 10 years ago, I didn't even bother to learn about survivorship because I thought, well, it's not really applicable to my practice, but boy, am I wrong. I think the lung cancer community have a lot to learn from our colleagues in other disease sites to help support our patients to live well with their cancer. We really need to start thinking about how to manage long-term physical, mental, emotional, social, financial effects of cancer. We need to learn from our colleagues about vocational rehabilitation, sexuality and intimacy, preventative health measures, and how to age well with cancer. We need to work with our patients, our family caregiver partners in developing more tools and resources and establish some guidelines to support them. And this has to be a collaborative effort. We need to work with our village to develop those things. And I really want to say it's not just about, I mean, our oncologists are super important. And as a nurse, of course, I'm biased, but I think it's also about our allied health professionals, our physios, our occupational therapists, our psychologists. We can all work together in finding ways to better promote health and well-being living with and beyond lung cancer. So that's all I have to say.
Thank you so much, Bonnie. You've just brought it all together for us. As we sit and think through, from those first symptoms or that first moment of detection to getting through the diagnostic journey to, living better with lung cancer and supporting everybody who's affected by lung cancer. It is such a fantastic space to be in because like I said, I'm like you. About a decade ago, I passed on the opportunity to help influence survivorship. And now I'm giving a lecture about, do we cure stage 4 lung cancer tomorrow, which I think is a great lecture to get to write as part of Lung Cancer Awareness Month. I appreciate we're over time, so I'm going to move forward with our closing remarks. I just want to acknowledge everyone today who made this possible. All of you who have shared your stories, whether you're a patient, you're a caregiver, you're a family member, thank you for your courage of being willing to share your lived experience. It's only through these stories that we are going to be able to make this journey a better one for those of us, for those around us. I'd like to thank the clinicians, the researchers, the nurses, and the social work. Thank you for turning science into care. I'd like to shout out to our policy leaders, our partners, and our advocates. Thank you for leaning into solutions. And I'd like to thank the Lung Cancer Canada team and their volunteers. Thank you for turning all of this intention into execution. Again, if I could distill all of today into one line, it's this: stories lead to steps forward, lead to system change. I'd once again like to thank our sponsors of today's events. We've been sponsored today by multiple partners, including Amgen, AstraZeneca, Bristol Myers Squibb, EMD Serono, Janssen, Merck, Regeneron, Roche, Pfizer, and Titan One. I'd also like to extend my heartfelt gratitude to the panelists and participants for all of your contributions and your commitment to improving lung cancer care. I'd like to encourage all of you to please stay engaged with Lung Cancer Canada. Again, we're the only national charity dedicated solely to lung cancer. As we've mentioned a few times, it is Lung Cancer Awareness Month right now, so we have a few activities that are ongoing. One opportunity is to engage with our Lung Cancer Canada policy series. This has been a new feature for us over the last couple of years. So this is the third installment in the policy series for 2025. And we're going to be talking about bridging the gap, precision medicine and lung cancer, both diagnosis and treatment. It's moderated by my predecessor, Dr. Stephanie Snow. So that event is going to be held Tuesday, November 18th at 2 p.m. You can sign up on the Lung Cancer Canada webpage. I would be remiss if I didn't mention our signature event for Lung Cancer Awareness Month, the Evening of Hope. This has really transformed over the last decade in which I've been involved with Lung Cancer Canada. There are now outposts of in-person activity all across the country. This year's Evening of Hope will be Sunday, November 23rd. This is a time to celebrate survivorship and usher in a hopeful future as we come together from coast to coast. There's a QR code here if you want to look and see if there's an event happening closer to you, and then there's a virtual aspect to it as well. So please sign up to join us for the Evening of Hope. A lot of what we've heard today is really lack of safe information. And so Lung Cancer Canada has looked to fill that gap. So we have your comprehensive guide to lung cancer. You can find it in its virtual format on our website. There are paper copies available across cancer centers across the country. This is a resource to share with patients, families, colleagues, and is a great first step in helping people walk their way through this journey. So please feel free to download that and share it widely. Together we can bridge the gap so that every person in Canada has timely, equitable, and effective diagnostics and treatments that they not only need, but they deserve. I just want to thank each and every one of you for being part of this work and for everything that you have done to try to change lives for lung cancer patients as a whole. So this is going to bring our Faces of Lung Cancer press briefing to an end. You will be able to find the entirety of the Faces of Lung Cancer report on our website. So again, thank you each for coming to bear witness with us today. And I look forward to seeing you at Lung Cancer Canada events over the course of the month, as well as moving forward. So thank you very much today.